Hi, everybody. I'm so sorry about that. We have had a bit of a frantic scramble as I found my presentation, which is on my desktop, but wouldn't download from the cloud. So we're here now. I'm sorry I'm a couple minutes late. Are we okay, Kathy? Can I just get a thumbs up from you to go ahead and get started?
Yep,
perfect.
Go ahead.
Okay. All right. So we're going to spend some time talking today about the late preterm infant. We're going to talk for hopefully just about 45 minutes. I'm hoping to make this a bit interactive. And so, Kathy, I'm hoping I can beg you to watch the chat, and I'm going to ask you guys for input. If you guys can, it's a lot more fun for me if it's interactive. I don't love presenting virtually. When there's going to be a couple of polling questions, if you guys can just unmute and answer the polling questions, it's way more fun. All right, so we're going to talk about the late preterm infant. I have no conflict of interest to declare. What I'm hoping is that by the end of the presentation, you'll be able to describe the epidemiology of the late preterm infant. You'll be able to describe the morbidity and mortality that's associated with late preterm infants. And then we can talk about different management strategies for the late preterm infant, both in hospital and post-discharge. Okay, so what we're going to talk about is that this is not an uncommon problem. We're talking about babies that are very, very familiar to both you and I. Annually, there's about 15 million babies born preterm globally, and preterm birth complications are the leading cause of death for children under age 5. Rate of preterm birth globally is somewhere in the range of 5 to 18%, meaning that it's about 1 in 10 babies, and this number is rising. Historically, these babies were called near term. They often are similar weight as term infants, and they're often kept in level 1 or 2 nurseries with their moms. And so there's a perception that these babies are just like term infants with no increased risk. However, like we're going to talk about today, we know that there's, we're starting to increasingly recognize that there's both increased morbidity and mortality with these late preterm infants. In 2005, the National Institute of Health recommended that there be a consistent definition for late preterm infants. And so late preterm infants are defined as babies who are 34 and 0 to 36 and 6 weeks. And what this does is this allows for a consistency in definition and tracking. And it also changes the nomenclature so that we're no longer thinking of these babies as near term. And allowing us to sort of really recognize these babies as the preterm infants that they are. If we switch it for a second now to Canada, preterm births account for about 8% of all births, and the late preterm infant is the most common. So 60 to 70% of preterm births are late preterm infants. So what this means in Canada is that there's about 30,000 preterm babies a year, of which 20,000 are late preterms. We know that singletons in the range of 34 to 36 weeks are the largest proportion of preterm babies and the fastest growing segment. And if we look at why those babies are born preterm, about 30 to 35% of them are medically indicated, and about 65 to 70% are because there's been PPROM, so preterm premature rupture of membranes, or there's been a spontaneous onset of labor. Okay, so we look next at reasons for the increase in preterm infants. What we know is that we tend to see more preterm births when there's been an increase in maternal age, which is happening. We're recognizing that there's more underlying maternal health problems like low or high BMIs, diabetes, and hypertension that can lead to more preterm births. There's a greater use of reproductive technology, which can lead to preterm births and also can lead to more multiple pregnancies, which then leads to more preterm births. We're doing a better job with medical surveillance and intervention, which means that we're then intervening sooner for both maternal and child health. And there's a better identification of infants at risk. And so then this sometimes leads to them being delivered earlier for infant reasons. So What perhaps we don't talk about quite as often is the increased risk and mortality with preterm infants. And when I was preparing for this talk, I found this a little bit surprising. So we know that the relative risk of mortality in the late preterm infant in Canada is 4.5. So it's 4.5 times more likely that you're going to die compared to term infants if you are a late preterm infant. And there's an increased risk in the first 28 days as well, so a risk of 5.9. That risk persists into the first year of life, so with an odds ratio of 3.7 to 4.5, and it seems as well to persist into adulthood. Now, I don't want to overstate this, because as you all know, that the vast majority of our late preterm infants do very well, and the infant mortality rate in Canada is low. It's about 4 in 1,000 or 0.4%. But when you then look at that increase, so you increase it to about 1% or 1.5%. And so even though it's a low risk, the late preterm infants do have a higher risk of dying in the first week, the first year after birth, and in later years. And typically the reason that they're dying is from congenital malformations, sepsis, and placental complications. So if we look at the first 0 to 6 days, the causes are things like congenital malformations, intrauterine demise, and asphyxia. Late preterm infants are much more likely to die from atelectasis, respiratory distress syndrome, maternal complications, and congenital malformations. From a week of age to 27 days, they're 3 times more likely to die from necrotizing enterocolitis, which makes sense, sepsis, and congenital malformations. Congenital malformations are overrepresented. So about 75% of deaths from congenital malformations occur in the first month of life versus 61% for terms. And this makes sense because these may be babies that were born preterm because their congenital malformations were identified. However, when we take the congenital malformations out of this group, late preterm infants are still twice as likely to die than their term counterparts. And this seems to persist even through the first year of life. So this perhaps explains some of the tension that you'll sometimes notice between the pediatricians and the obstetricians, where you've got obstetricians who are trying to balance maternal and fetal health and are looking to deliver babies, and pediatricians are saying, like, hang on a second, maybe these preterm infants aren't quite as low risk as we think they are. And it sometimes results in some interesting conversations trying to around the timing of delivery. And I'm always grateful that I don't have to make that choice. So just remembering that mortality is a very, very rare thing in late preterm infants. We're going to switch and talk about now is morbidity, which is far more common. And what we're going to do is we're going to work through each of the common morbidities that we see in late preterm infants using different cases. And this is where I'm going to start bugging you guys and get you guys to participate as well. And if you guys don't volunteer, I'm going to start picking on you. Okay, so case number 1 is an infant who's 36 and 4. His mom was 33 years old. I've done it this way for confidentiality for slides. A G3P2, had 2 prior C-sections. She'd had a normal pregnancy and a normal ultrasound and went into labor spontaneously, then progressed to C-section at 36 weeks, 4 days. APGARs were 9 and 9, and the birth weight was 2780, which is a typical size for a baby at 36 and 4. So I want to see by show of hands or something, how many of you are happy with this baby at this point, and how many of you would keep this baby in peri-sound? So type in the chat or unmute or put a thumbs up or something. I see a thumbs up. People are happy. And how many of you would keep this baby in peri-sound at this point? Oh, I see some stuff in the chat. Let's see what the chat. Depending on blood sugars and feeding, happy in peri-sound, happy so far, would have kept peri-sound. Perfect, excellent. Okay. All right. So subsequently, and I think that's right. I would not have necessarily automatically transferred this. Can you guys see if I have the chat there? Are you guys seeing that? Do I need to move that over?
Yeah, we can see the slide if that's what you're referring to.
Can you see the chat though as well, or
yes.
not? Yes, you can.
Yeah,
okay,
they can bring it up on the side.
Okay, I'll move the chat over there, and then if that's just type in the chat if that's bugging you guys. It's just I can't watch it to see what your answer.
We can't see your chat, Michelle.
Oh, okay, perfect. Excellent. Wonderful. Okay, so the baby developed respiratory distress shortly after delivery, was then settled on CPAP at 25% oxygen overnight. So this baby was with us. SATs were 94%, and the CPAP was discontinued the next morning. So far, so good. However, the nurses, I was a physician on call, and the nurses then called me as a physician on call due to increased respiratory distress. I restarted the CPAP and I did a chest x-ray. And so this is what the chest x-ray looked like. So I'm wondering if you guys can type in the chat or just speak out loud what you see on this chest x-ray. I'll give you some options. RDS, transient tachypnea of the newborn, pneumonia, pneumothorax. What are you seeing? So yeah, so Owen's seeing a pneumothorax. Hepatization of the lung. So I think you're describing the dense texture. And so what you're noticing on this x-ray is that you've got lungs that look very dense and abnormal. So this baby actually had respiratory distress syndrome. And as a result of that, developed bilateral pneumothoraces. So what happened next was the baby was intubated with rapid sequence induction. We did drainage, needle drainage of the pneumothoraces, inserted bilateral chest tubes and gave the baby surfactant. And this is the x-ray afterwards. You can see now that the baby is intubated, has got lines in place, has got chest tubes both places, the lungs have reinflated, but you've got lung fields that still look a bit abnormal, so still look like respiratory distress syndrome. So fortunately, this baby did very well. The baby had resolution of the pneumothoraces and the chest tubes were able to be discontinued. You would send baby out of peri-sound now. True story. You would absolutely send the baby out of peri-sound now. So you would actually send the baby out of peri-sound as soon as they developed any respiratory symptoms. I know it's challenging because now anytime a baby has any respiratory symptoms, they need to be moved by critical, which is a big pain, and we can talk about it at the end, but safest for babies. But yes, absolutely. We actually kept this baby at Soldiers, and I'm not sure, it was a case from a few years ago. I think we probably now would be talking to the city about transferring this baby as well. So this baby had their chest tubes discontinued, were extubated, and discharged home on day 13. I followed this baby in the neonatal follow-up clinic. This baby fortunately was developmentally normal. However, interestingly, developed asthma, and I followed this kid in asthma clinic until age 7, and then he outgrew his asthma and has been well. So I guess the question for you guys is, how many of you guys are surprised at this degree of respiratory illness from a baby who was 36 weeks and 4 days and otherwise well? Yeah, so I see Catherine. Yeah, so you are surprised. So we were a bit surprised as well. And certainly this is not the typical case that we see, but you absolutely can. There's some good physiologic reasons for why the late preterm infant develops respiratory difficulty. It's something we need to watch for really carefully. So what we know is that from 34 to 37 weeks, the terminal respiratory units evolve from alveoli saccules to mature alveoli. And at the same time, you get the pulmonary capillaries bulging into the terminal sacs. But in that period of time, you start to get adult-sized pools of surfactant are attained. And so babies born prior to that 37 weeks aren't there yet. And so they have lungs that are not yet fully developed, and they don't have the adult amount of surfactant. So there's good physiologic reasons why they develop respiratory difficulty. And so if you're born prior to 37 weeks, you are more likely to have delayed fluid absorption, which is transient tachypnea of the newborn. You're more likely to have surfactant deficiency, and you're more likely to have poor gas exchange. And we know that late preterm infants account for a very important proportion of the newborns who require neonatal intensive care, mainly because of this respiratory morbidity. And so in a study that was done by the Canadian Neonatal Network, the incidence of respiratory distress in late preterm infants was about 15%. And so it's something you've got to watch for carefully, especially if you've got those babies who otherwise appear well and we're leaving in level 1 centers. You've got to watch really carefully for the development of respiratory distress. For late preterm infants, the incidence of respiratory distress syndrome, or RDS, is about 10% at 34 weeks and drops to 2.8% at 36 weeks, which makes sense because your lungs are developing through that time. and yet they have a 40 times greater odds of developing respiratory distress syndrome compared to the term infant, which is more like 0.3%. What's interesting is that even though we give antenatal steroids to our late preterm infants, antenatal steroids do not seem to benefit our late preterm infants in terms of protecting them from respiratory distress syndrome the way they do for our earlier preterm infants. We know that obviously if they are more likely to have respiratory distress syndrome, they're also more likely to require mechanical ventilation compared to the term counterparts. However, many, if not most of these late preterm infants can still be managed with non-invasive ventilation or CPAP, obviously still at a level 2 center. So not all of them require mechanical ventilation. If we look next at transient tachypnea of the newborn, which is more common, I thought this was fascinating that alveolar fluid clearance is also developmentally regulated. And so you actually get a decrease in alveolar fluid production near term, and you get epithelial sodium channels increasing, and that's regulated by changes in maternal hormones. When I started reading about this, I was so excited. I thought it was the coolest thing ever. And I tried to get my 17-year-old really excited about it, and she wasn't quite as excited as I was. Anyway, it makes sense that that we see more transient tachypnea of the newborn in these late preterm infants, and particularly that group. If you are going to be delivering a late preterm infant by C-section, you now have two risk factors. You've got a baby that is not going through the process of delivery, and they're late preterm, that's got to be a baby that you've got to anticipate that that it may be quite likely that they're going to develop transient tachypnea of the newborn or respiratory distress. And the rates in the late preterm infant are about 4 to 10%. And interestingly, TTN does improve if the moms have gotten antenatal steroids beforehand. Apnea of prematurity also is more common in the late preterm infants. We don't think about it for our late preterm infants. We tend to think about it more for our 30 to 32 week group, but it affects up to 10% of our late preterm infants. And it's often not identified in the first days of life. So again, these are babies that if they're being cared for on a combined care unit, we've got to be watching them really carefully and have a high index of suspicion, because sometimes we may not necessarily see that apnea of prematurity develop if they've been discharged home very quickly. Late preterm infants also have a higher risk of later respiratory complications. So those of you who are emerge docs are going to see these kiddos coming in with bronchiolitis, with pneumonia and wheezing. And they're somewhere between 1 to 2 times more likely than their term counterparts to develop bronchiolitis, pneumonia, and wheezing. So when I was an NICU fellow, I thought that babies at born more than 32 weeks did not get respiratory distress syndrome. Because I didn't see it, because we didn't see babies more than 32 weeks. We didn't have to do prenatal consults for babies who were more than 32 weeks. And when I myself was pregnant, I did a little dance of joy because I thought at 32 weeks I had gotten there. However, when I became a staff at a level 2 nursery, what I realized is that late preterm infants can in fact get both respiratory distress syndrome and transient tachypnea of the newborn, and they can be really sick. They can get apnea of prematurity, and they're also more likely to get readmitted for respiratory complications after discharge home, particularly in that first year of life. Before I move on to the next morbidity, are there any questions about the respiratory complications of late preterm infants? Okay, I'm going to move on. I get another chance to pick on you guys in a moment. So this is case C. This mom was about 22. She was a G3P1 SA1 mom. She'd had a normal pregnancy. Her blood group was A negative, and she'd received ROGAM during her delivery. She had a spontaneous vaginal delivery at 36 weeks at one of our local level 1 hospitals. The birth weight was 2,500 grams, and the baby did not require any resuscitation. The baby did beautifully. The baby was blood group A positive, and the Coombs was positive. The DAT was positive. On day 2 of life, the weight was 2360, so the baby was 5.6% below birth weight, and the Billy was 197. I'm going to put that on the graph for you. So this should be familiar to all of you. This is the CPS risk graph. And so you've got a baby now who's got a bilirubin who's just at the cutoff of the high intermediate zone. So my question for you guys is, what would you guys like to do now? Your options are, you're done and this baby does not require any more monitoring for bilirubins. This baby requires a repeat bilirubin within 24 hours. This baby requires a repeat bilirubin, but we're going to do it in 3 or 4 days. This baby requires phototherapy, or I don't know, I'd like to phone a friend, phone my pediatrician colleague. So please put them in the chat. Otherwise, I'm going to pick on Catherine or Kim. Or Judy. I can pick on Judy too.
Michelle, it's Catherine. Sorry, the baby was 24 hours old and it was 197. Is that what you said?
The baby at that point was actually 37 hours old. It's here on the graph. It's about 37 hours old and was 197. So it was in the high intermediate zone. And so it's right where you see. And so Kim is inclined to recheck and would recheck in 24 hours and would be inclined to begin phototherapy. Would anybody do anything differently? Start phototherapy and repeat in 12 hours. Okay, excellent. So what this level 1 did is that they repeated the bilirubin 4 days later. And Catherine, you said you would start photo as well. Yep. So if you look at what they did, so this, the bilirubin was here at just over 40 hours, but the baby was 2 days old and they'd done the bili prior to discharge. And this is where it was on the last slide. And so if you see that the important thing is that you need to recognize that this baby would fall on the highest risk curve. So they've got 2 risk factors. They've got both late prematurity, and they also have a positive DAT. And the tricky part for the CPS recommendations is that their definition of late prematurity is different than the NIH one. So late prematurity, in terms of when we think about the late preterm, and the talk I'm giving you is under 37 weeks. But for the CPS graphs, they fall into the higher risk category when they're under 38 weeks. And so that's, you really got to pay attention. In our experience, you really got to pay attention, especially to those 37-week infants, because people sometimes miss that they fall into the higher risk graph. And so in fact, at 48 hours, this baby fell above the phototherapy threshold. And then when they called us 4 days later, the baby certainly fell above the phototherapy threshold, way above the phototherapy threshold. And in fact, this is the exchange curve. And when they called us, the baby was above exchange range by the time they repeated it a few days later. So fortunately, this baby did well. The baby was transferred down to our center from the level 1. We provided the baby intensive phototherapy, provided the baby hydration, addressed the feeding difficulties, and the baby did very well. So the question is, why did this happen? So we know that this happens not infrequently. And after this case happened, we saw one happen at most of the other level 1s. And we actually did a whole talk on jaundice and bilirubin and dehydration that we brought to all of our level 1 hospitals. And so it is not, it's a common problem. And I think it's a cognitive error that people make, because when what you're doing most of the time is looking after term infants. You're so used to looking at the same curve on that CPS scale all the time that it's sometimes hard to remember which babies fall into the higher risk curve, and that these late preterm infants need to be looked at a little bit differently. So what likely happened is they treated them the same as the 10 other term infants they were looking at that day. They had premature closure, so they stopped sort of thinking, and then they continued on the same course of action. And I don't think anybody else plotted this baby independently, and so nobody else picked up that an initial error had been made on that graph. This is so common. It happens at lots of other sites. It happens at our sites. We find we have to go back and educate about jaundice all the time. And if you guys want me to, I'll come back and do a talk on jaundice, just about jaundice as well. We know that in the late preterm infant, 54% of babies will develop jaundice versus 38% of term infants. It's the most common cause of kernicterus, and late preterm infants have a higher risk of, most common cause of readmission, not kernicterus, and late preterm infants have a higher risk of kernicterus than their term counterparts. However, it's still uncommon. So you need a bilirubin above 425, and 2/3 of babies with kernicterus had a bilirubin of more than 600. So the CPS published guidelines that will look very familiar to you guys, put out in 2007 and reaffirmed in 2018 on the detection and management of hyperbilirubinemia in term and late preterm infants, and we're going to focus on the late preterm infants. And so their consensus statement were that we needed to test all mums of ABO and RH blood types. Their recommendation is that you do blood type and DAT in babies who are jaundiced. And if you have a mom who's type O and a baby who's in the high intermediate zone, you then also check those babies because you'll move that baby, a baby in the high intermediate zone who then has a positive DAT may need intervention. This is what the CPS says. So they say wait and see where that baby's bilirubin plots. What we found at Soldiers is that when we did that, we missed a whole bunch of babies who had a positive DAT who were in the high intermediate zone because people forgot to go back and do that second step. And so what we do now is we test all babies and all mums. If a mom is O positive, all babies get a DAT done. I know some of our level 1 centers have had trouble with that. They've had trouble getting their lab to agree to that. My foggy recollection is that you guys in Parry Sound have taken the same practice and have been able to do that, I think. Correct me if I'm wrong. They also recommend testing certain at-risk infants for G6PD if they're very severe, so they have severe jaundice, and if they have certain ethnic origins, so Mediterranean, Middle Eastern, African, or Southeast Asian. If you have a mom who hasn't been tested, and then we test the cord blood for their ABO and RH blood type. Bilirubins need to be done on all babies prior to discharge. Transcutaneous is fine. And then it needs to be plotted on the predictive nomogram that I've shown you guys. And I know you guys have here. I know you guys have got great policies here because I know you guys have worked on them really hard. Any baby that's been discharged prior to 24 hours needs to be seen within 24 hours to have another Billy done. A bilirubin needs to be done on any visibly jaundiced baby prior to that discharge if they're jaundiced already. And if they have severe or prolonged hyperbilirubinemia, they need to be investigated. And at some point, they need to have a conjugated bilirubin done as well to make sure we're not missing a conjugated hyperbilirubinemia, which would make us think about a whole bunch of different stuff. This again should look quite familiar to everybody, and I know that this is part of your policy here. The CPS published a risk stratification, so babies are graphed as low, low intermediate, high intermediate, or high, and then the management depends on their other risk factors. So a baby who's 38 weeks and DAT negative, you may only be intervening, and there is an error that somebody picked up on here. When I presented this in the past, I apologize. I couldn't pull up my most recent slides. That the low risk term infant does not need intervention at high intermediate risk. They're fine. They get routine care. But a term infant who is DAT positive or a preterm infant in the high or high intermediate zone may very well require phototherapy and it needs intervention within 24 hours. And then our babies who are in the high intermediate zone who are both late preterm and DAT positive are going to need intervention at a much, much lower bilirubin level. And so those, and you can see that even in some of those low intermediate zone babies, those are the ones that get missed. The babies that are in the low intermediate zone, but late preterm and DAT positive. And some of those babies require both follow-up and intervention. And they get missed because everybody thinks, oh, low intermediate zone, we don't need to do anything with that, because you don't need to do anything with that in the other two categories. This is the phototherapy curve that the CPS published, and again, it will be very familiar to you. I know you guys have a home phototherapy program here. We typically don't use it if there's other significant risk factors. If you've got a family where you know that there's isoimmunization, you're worried about hemolysis, if there's been significant asphyxia, or if there's other risk factors with the baby, we may not choose to do home phototherapy. You can use home phototherapy if you've got a transcutaneous billy that's sort of safely below these that aren't really getting close to the guidelines, and monitor. If you're not sure, just call us and we're happy to chat about it. Just a little reminder, you guys probably do not have this here because this wouldn't apply to infants that you would typically keep here, but our babies who are in the later preterms of 34 weekers up to 35 weeks, you can't use the CPS chart because they that only applies to 35 weeks plus. And so there is another phototherapy chart that looks a little bit different that we use for infants who are earlier preterm, the earlier, later preterm. Okay, so how do we prevent this from happening again? It's staff education. Sorry, I'm just gonna tell my secretary I can't talk right now. Becky, I'm just giving rounds. Can I call you back? Sorry. Staff education using the graphs, follow up every 24 hours when they're in the high risk zone or when they're deemed high risk based on the CPS or if they've received phototherapy. And if you've got a baby who's on more than single phototherapy or they're not improving, please call us and we're happy to help. Any questions about jaundice before I move on to the next one? Okay, we're doing a quick tour of all things late preterm. 35-week, 3-day baby, born again to a 30-year-old G9T3P1L4A4 mom. She was late to antenatal care, so had not had a glucose tolerance test done. Otherwise, she had a normal pregnancy. She presented in threatened preterm labor. Ultrasound showed oligohydramnios, and she was delivered by C-section due to prior cesarean section and concern for fetal health. At delivery, APGARs were 9 and 9. Baby was 2490, which is on the 50th percentile. The baby required CPAP briefly in the delivery room and then was fine from a respiratory point of view. Physical exam was normal. And on the initial glucose screen, I'm going to change this. It actually was 1.7. It makes it a little bit less confusing for you guys. So what I want to know is, what would you guys do? How many of you guys would repeat it? How many of you guys would offer the baby formula? How many of you guys would do dextrose gel? And how many of you guys would be starting an IV and calling us and transferring this baby? People are muddling. Can I pick on Kim and Judy and Catherine again? Begin formula and recheck. Okay, perfect. All right, we have a vote. Supplement formula and recheck if lab results similar, consult peds and plan to transfer. Okay, perfect. So for this baby, we actually ended up starting an intravenous, gave the baby D10 bolus. I'll talk a little bit about that and started on TFI of 80. The baby had persistent hypoglycemia and required up to D12.5W and a TFI of 120, which is a very high need for dextrose. It required a glucagon infusion and then had critical blood work sent and actually turned out to have transient hyperinsulinism. So the mom likely had abnormal glucose tolerance, which we see. So the baby had hyperinsulinism because likely mom had abnormal glucose tolerance, which hadn't been screened for in pregnancy. And then gradually this baby had resolution of the hypoglycemia and is fine. This was a bit extreme. We didn't see this very often. However, we had a run of about 3 or 4 late preterms that had exactly the same course, which made us start looking for hypoglycemia or be much more careful with hypoglycemia. And so again, there's really good reasons for late preterm infants developing hypoglycemia. They tend to have lower glycogen stores to start with. They often don't feed very well. They have immature compensatory enzymes, and they're subjected to many more stresses, so cold, infection, and breathing. So the risk in a late preterm infant is about 7 times higher than in the term infant hypoglycemia. The CPS also came out in November of 2019 with the screening and management of newborns at risk for low blood sugar. This I'm going to just skip over because it's actually the old one, not the new one, but you guys also have a hypoglycemia screening protocol that's based on the 2019 CPS pathway. And when you've got a baby who's at 1.7, you can use Dextrogel first. It's low enough that you wouldn't be supplementing with formula right away. If you'd use Dextrogel and try to get them up. And often we can actually prevent admission to hospital or admission to NICU or IV with Dextrogel. And if that didn't come up right away, then you'd be starting an intravenous and calling us. So 1.7 is right on that transition. So important to have a policy around hypoglycemia based on the CPS statement. I think you guys also have one locally, and I know from the discussions that I've had with many of you that you guys are familiar with it, you know how to use it. Again, in my experience, even in our level 2, this causes great consternation and so much confusion. And it seems like we need to review the hypoglycemia protocols review them constantly. And Catherine is saying that I would have done Dextrogel if it was at the 2-hour check. 1.8 would feed with formula recheck closely. And I think I have to go back. I know 1.8 is right at the cutoff, and at 1.8 you are correct. If it had been below 1.0 to 1.7 or below, that you are right that that at 1.8 you're okay to use formula and recheck. You just need to watch this baby very carefully. So it's important to have a hypoglycemia policy that not only that you have it, but that everybody's familiar with. And what we're finding locally at Soldiers is that we need to review this pretty consistently. We do it with orientation with our nurses all the time. We review it with the physicians. We present to our family docs locally as well as elsewhere. And it's just something that we need to keep working on because people get confused. It takes some reminders about how to work through it to make sure we're not missing it. Not missing hypoglycemia. Other morbidities that are more common in the late preterm infant include things like temperature instability. They're more likely to require a sepsis evaluation. They're more likely to require intravenous fluids, and they're more likely after discharge to require readmission. So it's not necessarily a completely benign condition. Okay, last morbidity. First, any questions about hypoglycemia before we move on to this last case? Okay, so baby B, this is a 20-year-old mom, G3P1. She was an insulin-dependent diabetic. Her hemoglobin A1C was 7.1%. And this was an LGA baby who had abnormal core Dopplers and was delivered by C-section for fetal reasons at 36 weeks. APGARs were 4, 6, and 7. The baby required bag valve mask for about 60 seconds and initially had poor tone and color. On exam, the birth weight was 35.86, so quite large for a 36-week infant, and the baby had some initial grunting and respiratory distress. Was on CPAP for about 36 hours and then started feeding at about day 2, and then started more successfully bottle feeding on day 7. And this sweet mom was done, and she said, when can I go home? And she wants to know, when is it likely that this baby's going to go home? So you have a 36-weeker who's now a week of age. What are you going to tell this mom? Type into the chat how you would answer this question. I'm going to make Tim respond. I haven't seen you respond yet, Tim.
I would leave that to my OB colleagues, thankfully.
Oh,
but
no.
I would suggest that she's not someone that I would be sending home eagerly.
And when do you think, for those of you who do more OB, when would you anticipate that this baby would be ready to go home? You're guessing. There's no right answer to this. When baby is ready, should be feeding, gaining weight, etc. Excellent, you're going to equivocate. So the answer for this baby, I think, surprised everybody. So there are some babies for sure who are ready to go home at 36 weeks. There's a few things about this. And was born to a mom who had insulin-dependent diabetes. And so these babies are terrible feeders and they don't go home for a while. And so I usually tell parents, my pat line is, pregnancies are 40 weeks for a reason. You can, expect that you'll probably go home about your due date, and anything before that is bonus. And in fact, this baby was in our NICU for another 3 full weeks, which was a bit surprising. So there's good reasons, again, why late preterm infants have difficulty feeding and why they may take a while. So they have lower oral motor tone. They have an immature suck and swallow. They have delayed neural maturation. They tend to have fewer awake and alert periods, and they tend to have a poorer posture control at breast. So again, they're 6.5 times more likely than term infants to have feeding difficulties. Oh, 3 weeks is a long time, but they need to be able to feed and gain. Yes, that's right, Judy. It was a long time. And so it's not that I would tell every single mom at 36 weeks that the baby's not going to go home, but I tend to use that language exactly. What is it they need to do to go home? They need to be feeding successfully. They need to be gaining weight. They need to be keeping their temperature. We're going to talk about what has to happen for them to go home in a minute. So the other thing I just want to remember is that we tell this to all of our babies. And so to all of our moms, when we discharge them from the level 2, that they require follow-up within 24 to 48 hours of discharge. And I have to say, shout out to the team in Parry Sound that you guys do an exceptional job of this. And this has been something, again, that I know there's been a lot of work with the maternal child group about how we get more urgent follow-up for these babies. And it's fantastic that we know that we're able to call the person who's on call for OB and deliveries, and you guys are able to cross cover and see your babies within 24 to 48 hours of discharge, which means that those families don't necessarily need to drive back to soldiers. And our experience from our end has been that it is seamless and fantastic. I know I called Kim yesterday about a baby who actually had to go home on home photo. And so I know that when we have these babies who are requiring quick follow-up, you guys are able to do that. And hopefully your experience on your end is seamless as well. But these late preterm infants require closer follow-up than some of our term babies. So summarizing what we're seeing, that there's a greater risk of mortality in the late preterm infant, a greater risk of morbidity in terms of things like respiratory difficulties, jaundice, hypoglycemia, and feeding. And they're more likely to show up in Tim's emergency department and require readmission to hospital. So what do we do about these babies? How do we manage these late preterm infants at home, or sorry, at the hospital? And what do we do with them? And how do we know when they're ready to go home? So in hospital, there needs to be an accurate assessment of gestational age. You guys are likely pretty comfortable keeping babies 36 weeks plus. I would imagine at 35 weeks, you're probably going to have a bit of a conversation with us. We have had some 35 weekers that sometimes are okay to stay, but it's a bit of a judgment call, and many of those babies come down to us. And so you really want to know that you've got an accurate gestational age when you're trying to make decisions about when they can go home. You also want to watch the respiratory status very carefully. You want to have policies around jaundice management and checking their glucose and temperature and feeding. And these are babies that we often, we need to remind ourselves, we need to remind our nursing staff that they need a closer degree of monitoring and supervision than the term infants because of this discussion we've just had around morbidity and mortality. We recommend admission criteria to NICU, so policies and consistent practices around when would you think about transferring these babies. Glucose monitoring policies, which I know that you guys have in Parry Sound, and jaundice assessment protocols, which again, I know you guys have in Parry Sound. And as I've said, we find that we need to not only have those policies, but go back and review them fairly frequently because sometimes they're a little bit confusing to work through. And we still find, as I said, we still find that soldiers that we still always get babies who have hypoglycemia that's missed and jaundice that's missed, and it's sort of it's ongoing education, ongoing diligence. When we look next at the discharge criteria, the American Academy of Pediatrics came out with a statement in 2008 around what we needed to do for these late preterm infants. And so they need to have vital signs that are normal for 12 hours. They need to have a normal physical exam. They need to have a minimum 48-hour stay in hospital. And I would say that's the bare minimum. They need to have passed one stool. They need to have 24 hours of successful feeding. You want to make sure that you're assessing the family and societal factors to make sure that you're not discharging a high risk baby, or you're setting them up to be successful. And follow up within 48 hours. And I'm just going to look at Catherine. So do you suggest closer monitoring of respiratory status and vitals with late preterms? I think when they're born well, we typically monitor them as we would a term baby. Perhaps we should change how often they get vitals. So yeah, that's exactly what I'm saying, is that we need to not treat them like late preterm. We need to not treat them like term infants, is that I would recommend doing vitals a bit more frequently. I know in our postnatal unit, I think after the first 12 hours, the vital signs get done like every 24 hours. It's very, very infrequent. And so for your late preterm infants, you probably want to be doing it more like every 4 hours because you want to be monitoring, particularly for the first 24, and I would say even for the first 48. You just want to have a closer eye on these babies. But so the CPS discharge criteria there, the CPS came up with a statement, it's just hot off the press in March of 2022. They published a consensus statement looking at the safe discharge of neonatal babies, and they're not quite as prescriptive as the AAP. However, they are, it's sort of the same concept. And so the babies need to have respiratory and temperature stability. We've already talked about that. They need to have adequate feeding skills. And I think this is the piece that we need to be really, really careful of, that we need to be making sure that the late preterm infants aren't running into trouble. And we see these babies referred back to us not infrequently when they run into trouble with dehydration and failure to thrive and poor weight gain, sort of in that first few weeks after discharge, which again, we're not necessarily surprised because they're late preterm. And these are babies that I often have a very low threshold for supplementing and that we're following much more closely. And then you want them after discharge to be followed up within 24 to 48 hours. Okay. Take home messages. Avoid the term near term because we need to remember that these babies are in fact preterm and treat them like they're preterm. They have a strikingly different incidence of morbidity and mortality. And so when we're making a decision around when to deliver these babies, it really does require a team approach, balancing maternal and fetal well-being, the potential for poor outcomes if the pregnancy is allowed to continue, as well as what we know about the late preterm infant and the types of morbidity that we tend to expect with the late preterm infant. When we have a late preterm infant that is born, we need to make sure that the in-hospital management is very careful, that there's very close supervision or close monitoring of the respiratory status, that we're careful, really careful about jaundice monitoring, and not only jaundice monitoring, but how we're interpreting that bilirubin, careful glucose screening, and careful monitoring of feeding and temperature. Really good discharge planning with follow-up within 24 to 48 hours, and then really good parental education around the kind of monitoring and the kind of watching they're going to want to do with their infant. Okay, I needed my cute kids a long time ago. I'm happy to end there, and I'm going to turn the slides off and stop screen sharing, and I'm happy to answer any questions or have any kind of discussion anybody would like to have.
If anyone has any questions, just unmute and ask.
You're very welcome. I've either put everybody to sleep or answered everybody's questions. I'm glad you found that helpful, Kim. Yeah, so I know that you guys have, I know locally you guys have good policies. I know because I know that we sort of think of ours as an ongoing evolution because the CPS keeps on putting out new statements and we keep on having to review them. And I can't say enough that it's not only reviewing the policies, but the education piece that goes with it is I find that we need to keep on reviewing it. Not sure if your late preterm policy is up to date. So if you guys are working on that, I'd be more than happy, Kim, to take a look at it for you if you'd like me to. I'm happy to help out. I did this talk for you guys for soldiers, for Huntsville, and at the Sick Kids Pediatric Update. So I'm like totally immersed in late preterm infants right now. So happy to look at it for you.
I'm not seeing any other questions. Thank you so much for presenting today.
Thank you so much for having me, guys. And I'm so happy as always to come back and happy to do. We have lots of talks that we've done elsewhere. And I'm also happy if there's particular things that you want covered, more than happy to do that. And as is the rest of my group, we've got people who've done things on DKA and all kinds of stuff. So just let me know. We're happy to do this again. Very welcome, Judy. All right. Thanks very much, everybody. I like much better seeing you all in person, but doing this virtually also I know works really well. It is very convenient for everybody. I hope everybody has a great long weekend.
Thank you very much, Dr. Gordon. Same to you.
Okay, bye.
Bye.
Thank you.